This month, I'm continuing the second part in a three-part series, really looking at healthcare process, sort of both upstream and downstream. So um, let's see, I think it would have been, this is July, we took hiatus in June. So I think it would have been in May. I gave the first part of this series, really focused on healthcare system process and how that process becomes data. Today, we're moving on to the next part, really focusing on the extension then of healthcare process into more of the financial and expenditure side. And next month in August, we'll extend this even further out into more advanced and complex payment mechanisms and innovation in healthcare payment mechanisms. So this would be, things along the lines coming from CMMI, the Centers for Medicare and Medicaid, innovations for payment and reimbursement, and talking about things like value-based care and accountable care organizations, and some of these newer, more complex payment mechanisms. So just starting out and kind of setting expectations or giving context. I really like, I guess I'll give an initial plug. So this book, Hacking Healthcare, is one of a really small number of books on healthcare that I recommend. This is actually from O'Reilly, which is primarily an IT and software publisher. This book is from the late 2010s, like somewhere around 2011 or 2012. Um, Really focused on meaningful use. If you're not familiar, meaningful use was a set of federal guidelines to really measure the quality and utility of electronic health records following ARA, the American Reinvestment and Recovery Act. And so these authors were really focused on an introduction to healthcare and healthcare process, and then particularly as it related to translating into standards and IT applications specifically for meaningful use. But it is, I would say, the only book that I've ever found on healthcare that I think actually does a reasonable job, or even attempts to do a reasonable job of introducing healthcare as a process and then translating that to other things. But they have a specific chapter in this book on an introduction to medical billing and reimbursement. And I personally love this little introduction that they give. This is literally how they open this chapter, and it's really apropos. So, medical billing in the United States ranks in our experience with nuclear physics and rocket design and challenges to mastery, et cetera, et cetera. We are not joking about this. Medical billing is one of the most difficult tasks that can be undertaken, and performing it successfully is an extraordinary feat. So that is their opening context. But then I do think it's worth knowing then to go on, they say, and this is as of 2013, the United States generates more than $3 trillion of medical spending per year, which leaves the payers in an all-out war to avoid paying as much as they can to the recipients, such as facilities, providers, and other services. That is really the fundamental situation that undergirds, I mean, the majority of what we'll be talking about. And so I think this is just the big picture context to keep in your mind through all of this. And I guess the other piece that I would have to give as part of the context on this is why this matters. I think it's really common, particularly in clinical research, to sort of ignore the money or the cost side of things and to focus exclusively on the clinical side of things. I think even within the clinical community, there's a feeling that um, it's sort of anathema to talk about or engage with the dollar side of this, and that it is sort of contrary to the care providing side. And so that is why I say this is polarizing, but it is also just really important, not just nationally in the United States, but internationally. I think even some of the other international communities with, obviously different demographics and different reimbursement and healthcare delivery systems, are also now really struggling with how to provide and finance healthcare. And so, I mean, I think, this idea of how both do we provide care and also how do we bill and pay for it is now, I would argue, a fairly significant global problem for a lot of, really major industrialized nations. Um, if you follow this at all, even casually, you probably know that, there are plenty of ideas and strong opinions on what are the problems and what are potential solutions. But I would say in actuality, we have fairly few actual desirable solutions that anyone is really willing to commit to at a large scale or societal level. Sometimes things are sort of jammed through unilaterally, but typically I would say they're not really considered particularly desirable solutions. Um, and part of the issue is that we don't even really have great consensus on, why is it so complicated? Why is it so expensive? We have truly, I would say, a pretty extensive laundry list of contributors to this, and I've tried to categorize them below. Um, you know, but it's difficult to even focus on any of these things, and we don't really have any ability to, uh, make any meaningful change to one of these without significantly having both intended and unintended consequences, if we can even modify some of these at all. And so generally, I think I would my, you know, um, I think research statement on this is I think this is important because it's really a societal level problem, as I'll get into more. And I think we need more people in clinical research thinking about and focusing on these topics and thinking about how do I try and do good research that incorporates expenditure into clinical research, as opposed to purely focusing exclusively on the pure clinical side only. And so now, some figures and charts that are maybe somewhat familiar, but just in terms of, again, setting the context or trying to argue for why this is important. So this is from Kaiser Family Foundation reporting. This is a visual diagram of the fiscal year 2024 US government federal expenditures. So the total budget is 6.9 trillion, and the overall just government healthcare funding was 1.9 trillion. So close to a third of all of the federal dollars spent went purely to healthcare. You can see that's double national defense. That's, you know, um, still larger than Social Security. It's just essentially the government spending on healthcare is by a decent margin the largest portion of our federal budget. Um, and this starts to then lead to really large scale government or societal level conversations about, you know, what things are we willing to potentially trade off at an entire societal level if we continue to spend this much on healthcare. And then similarly, this is a comparison of the United States on per capita spending on healthcare relative to other countries. So you can see, on health spending per capita, the US is an outlier. And this is even without factoring in outcomes or, utility or any other metrics in terms of how efficient or optimal is the US at achieving health outcomes relative to any of these other places. But so again, just trying to set some amount of justification for where, why is this important and why should we be thinking about and talking about these concepts? And why should you take the time to go through all the pieces of this talk and think about starting to focus on some of these things in your research? And I think this is maybe my last slide on trying to justify this. I can find a lot of justifications for this. So I wanted to set this up well. So if you don't know him, this is Amitabh Chandra. He's a fairly prominent health economist at Harvard, as well as being part of the NEBER, National Bureau of Economic Research, and several other prominent national economic research and forecasting organizations in the US. And parts of the areas that he works on are actually in things like drug pricing, and other parts of technology assessment, overall kind of governmental and societal level function of both reimbursement and expenditures. And he is one of at least a handful of people that have started to talk about these pretty, I would say, controversial ideas. So I already saw him give a talk, probably really now close to 10 years ago, on this topic, but really introducing the idea that these are my words, not other people, but we're essentially at the point of being able to, or already producing therapeutics that are essentially capable of destroying our entire economy. So, we basically now are at the point of developing not just treatments, but fully curative therapeutics. So whether those are drugs or procedures or other types of things that are both so effective that they are worth a large amount of money, but also so expensive that we could not even really pay for them for the populations that need them without trading things off at a societal level. So, you know, maybe some of the earliest drugs in this category were hepatitis C, not just treatments, but these are curative therapies. So, the costs of long-term chronic hepatitis C are very large. And we have something on the order of 2.4 million people with chronic hepatitis C in the United States. And so, the lifetime costs of living with that, receiving an actual curative treatment for somewhere in the order of 84 to $90,000 is actually essentially a money saving investment over the lifetime of a patient. But we also would need to invest something on the order of $200 billion to actually think about paying for that type of curative treatment for everyone with that disease in the United States. And then even more recently, we have, even newer drugs that are even more expensive. And these are now focused on relatively rare drugs or relatively rare diseases and conditions compared to something like hepatitis C, but orders of magnitude more expensive. So Hemgenix, an intended curative treatment for hemophilia B, that's a small population of 5,500 people approximately, but a curative treatment is about $3.5 million. I'm not sure of the pronunciation. I think Elevidys. This is a intended curative treatment for Duchenne muscular dystrophy at 3.2 million for a population of 30,000 people. And so these are just three conditions, with a small subset of drugs. But I mean, I think Amitabh Chandra and others have sort of brought up this idea of we're sort of at the point of really needing to consider not can we develop or invent these types of treatments, but should we, given that, we're at the point of really either needing to think about how much education would we give up at a societal level to pay for these things, or how much defense are we willing to give up, or we're looking at care rationing, which is hugely controversial, and something that I think for the most part, people are unwilling to talk about or consider explicitly, even if it's already happening in many cases implicitly. And another sort of just big picture concept to talk about and reinforce. So, right, so I've set up this justification. Why are we talking about this? Why is it important? I think another piece to really keep in mind is just the overwhelming complexity of the entire system, not just on a delivery level, but also on a finance and reimbursement level. So, I think a lot of times people generally will sort of pick one or two boogeymen within the healthcare system you identify as, the major culprit in the issues with healthcare or the high cost of healthcare, right? So it's the doctor's fault. They make too much money. It's pharma's fault. They produce all of these really expensive drugs, or, it's the lifestyle decision fault of us as a society, right? We can't commit to healthy lifestyles. But I think the thing that is maybe less obvious is all of these pieces are just completely interconnected. And so it's virtually impossible to even attempt to modify any of these things without affecting many, many other pieces of the healthcare system, right? So any single piece that you try to modify, even at a financial level, you're going to have both the intended consequences as well as typically fairly significant unintended consequences also, right? And so um, this really is quite a bit more complicated than simply picking one thing often and trying to move forward with it. And again, this is a theme that I talk about in these talks, but this is also often why I think we tend to see very incremental sort of technical modification to healthcare in America, right? So rather than large scale adding or removing things, often we see, taking one specific thing and modifying it very specifically. Okay, so a lot setting up this talk and in my opinion, the importance. So moving on to thinking about the objectives and what do I want to get out of today. So um, I've tried to make this relatively approachable, but it is still somewhat dense. Every slide, if not every topic in this talk, basically could be a full, at least hour-long discrete lecture. There is just almost an infinite amount of ideas and topics and information you could give on most of these topics. This is also, when I was looking back at this, a pretty mechanistic talk, I would say. This is pretty much, I would say, most of this is focused on the nuts and bolts of, terminologies and how do pieces work and how does a reimbursement mechanism work? Because I think that that is really fundamental to understanding all of the other sort of downstream and more complicated concepts. And so I would say a major goal that I have today is simply recognizing, understanding major aspects of the process and the terminologies. Um, and so, again, thinking about the application to research and into researchers, I think, two big picture things would be one, recognizing that colloquially, dollars are important in medical research. Trying to stay away from the concept of costs or economic analysis or financial analysis, because a lot of those have fairly specific terms, but so just generally dollars. Um, and that also, while recognizing that all of these are really complicated, I think it's really important and worthwhile to start thinking about these more broadly and trying to include them more in research. Okay, so really now jumping into the true nuts and bolts of this content. I think this is the most fundamental piece we can get to. So thinking about the terms charges and costs and payments. So anytime you're really talking about any type of dollar concept in healthcare, I think a lot of these terms get thrown around pretty, you know, often and sometimes interchangeably. So um, charges, which get talked about often and are probably the most accessible, um, unfortunately, while they're the most available, they are by far the least valuable, interesting, usable aspect of any type of dollar amount in healthcare. Um, I think you maybe could even argue or use the terms that, in some sense, they are fake. They are not real. They are unrelated to actual dollar amounts or costs or anything else interesting in healthcare. We'll talk a little bit more about why that is and how to think about that later on. Um, but so charges, as opposed to costs, costs would be the true expense of delivering care, right? So this would be, you know, if you perform a surgery, it's the actual financial cost in terms of the tangible things and the intangible things that goes into delivering that care. Costs are really, really valuable and useful for incorporating into research. They're also very hard to access for reasons that we can get into. Similar to cost, payments are really, really useful. So costs are on the provider side. That's what it costs a provider to provision care. Payments are what a payer actually sends to the provider for providing that care. So payers will typically negotiate the payments that they're sending. Um, and, you know, payments are typically different than costs. And so the difference in a payment and a cost is the margin. So that's essentially the profit or the loss that a provider is going to receive. Now, the problem is that for the most part in America, um, it is fairly difficult to get costs, payments, and margin unless you are essentially like doing financial analysis or working in the accounting department of a hospital or a healthcare system. There are really, unfortunately, you know, uh, not a huge number of resources to get to using those for true, um, expenditures focused analysis. At the end of this, I'll talk about some of the resources, but I think this is the first place where we start to see some obstacles to doing this. Yes, it's really valuable. In my opinion, it is not sufficient to do this research with charges. It is difficult to get to the actual dollar amounts that are useful of costs and payments. Um, so moving on a little bit, starting to think about this in another way, as well as sort of the overall process. So, and breaking this out into provider versus payer sides of things. So, on the provider side, as I was talking about, there's this whole sort of milieu of tangible and intangible stuff that goes into understanding the costs of the services that you provide. And what happens is that once you've identified the cost is converted into a charge. And this is where, to some degree, reality can break down. There is some actual rationale that goes into generating or figuring out a charge, calculating a charge for a service. But there is also something that I would describe as magic. This magic is sort of the piece that's unknown. Basically, accounting departments and hospitals, healthcare systems can basically generate, charges however they want. They could take a cost and they could simply mark it up by 10%. Maybe they decide there are certain services that they would like to try to make a huge amount of money on, and so they mark it up 10 million% without really having a lot of insight into the accounting level decision making for a provider. It's almost impossible to understand what the relationship between a cost and a charge is. And so one reason that charges are marked up is because of this next piece. So charges are what go out to payers on claims. So you're a provider, you've provided care for a patient, you need to get paid for that care. You're going to generate a claim and send it to the payer. You're going to put down typically all of the charges for that stuff into a claim and send it to the payer. Payers understand that charges are marked up. So typically they will never pay what the actual sum of charges is. They negotiate lower rates. And again, gets fairly complicated, right? I talk about this in a little bit more detail later on. But payers will typically say there's no way we're going to pay these charges. We will pay you whatever rate we've negotiated. And then that becomes the payment that goes back to the provider. And this process is repeated, tens of millions of times, every week with every single healthcare transaction that's essentially happening. And all of these providers are basically negotiating with all of these payers who are counter negotiating. And so this is where typically, we see one instantiation of what we would think of as an arms race in healthcare, right? So we basically have providers trying to get as much money and efficiency as they can from this process. We have payers attempting to pay as little as they can and get as most efficiency from their side. And the two constantly sort of going back and forth on what should something cost? What are we willing to pay for it? And keeping in mind that, even though I have this described as payer, we have many different types of payers. There are government payers who actually tend not to really negotiate a lot of this, and private payers. But even on the private payer side, think about the number of private insurance companies we have for commercial health insurance, right? Typically, a provider has to negotiate with each of those individually. or maybe even has specific populations carved out. So, we have a PPO plan that maybe needs one contract versus PCO or other types of specific care contracts. And all of these oftentimes will receive specific, negotiated contracts between payers and providers. And so, you know, this is another place where when we talk about like the administrative burden of healthcare in America and how does that contribute to the complexity and the cost, this is one piece where we see this, both in terms of the process of getting all the way to, pricing and even just generating the bills, and then how do we get those things paid, and how much human negotiation and work needs to happen in the middle of that for this process to even happen. And so I think that this is implicit, but I'll say it explicitly. Healthcare accounting is pretty much fundamental to almost everything that we're talking about. Um, Accounting would generally, I say, sound pretty boring to talk about. But in terms of healthcare financing and reimbursement, it is literally the fundamental glue that holds everything together. And I would say it's pretty much impossible to understand the nuts and bolts of this without talking about healthcare accounting at some level, right? So healthcare accounting and the people and organizations running healthcare accounting in hospitals, healthcare systems, doctors' offices, they are typically the driver of a lot of big important questions, like what is the cost of a specific service? Once we know the cost, how much should we mark the charges down for that service? When we as a provider go to negotiate with a payer, what should we be negotiating for? Should we not pay attention to certain service charges? Are there things that we should pay a lot of attention to? And then ultimately, healthcare accounting is also what's going to be looking at payments coming in and figuring out what is our margin, what's our profit or our loss, which is important fundamentally because, for something like a nonprofit hospital, this is still essentially what allows you to keep lights on and doors open and seeing patients. So even taking it apart from a pure sort of profit sense, margin is always important because even in something that is not profit oriented, it is what allows you to function. Okay, so the first big question, what does something cost? This is important to talk about because it leads to answers to really big questions that I think come up often, right? So like, why is my hospital bill so large? And why do I pay $20 for a single tab of aspirin? This all comes down to not just healthcare accounting and hospital accounting, but specifically cost-based accounting, which, if you're unfamiliar, is, I would guess, probably the most common approach to accounting generally in business. So in cost-based accounting, you're basically looking at the things that you can get paid for in your business, and then figuring out how do we increase the price of something so we can make or get compensated for all the things that we cannot get paid for. Okay, so this is where we talk about tangible or billable types of items versus intangible and non-billable. So think about a hospital visit. There are a lot of pieces of a hospital visit that a provider can get paid for, right? So disposable equipment, things that they have bought and then provide. So drugs and, liquids that are going into IVs and, tubing and syringes and all of those types of things that they buy and they use. And then, they have a sense of how much did we pay for those things and how much do we need to bill for them. And then similarly, services, but specifically billable services. So again, going back to the last talk, these would be things coming from LIPs, licensed independent practitioners. So if someone like a physician or an advanced practice provider can see you, it's easier to figure out how much do those things cost because we have the ability to bill for those things, and we know, okay, so this provider inserted, this line into you, and that can get paid at this rate, right? So those are all pretty clear, tangible things that it's a little bit easier to figure out what does this cost, and so how much do we need to get paid for those things. The problem is that a hospital has a huge number of things that they cannot bill for directly that are critical to them, again, keeping doors open and lights on. So things like their utilities, their electric bill, their water bill, their real estate costs of owning or renting their land and their buildings, the cleaning, the servicing of their debt, their IT services. These are all things that are fundamental and necessary to get paid for that basically cannot show up on a patient-facing bill. That does not mean they do not get paid for. What that means is that all of those costs are estimated and then jammed into the things that you can get paid for. This is, again, one reason why aspirin costs $20 on a hospital bill. Maybe not the only reason, but a major reason, right? 1 cent of that is for the cost of the aspirin, and $19.99 is for things like paying for electric and water and cleaning costs and real estate, et cetera. And so down at the bottom, I've tried to illustrate this again, simply a little bit more visually and simply, right? So you have all of these billable types of things combined with the non-billable, and ultimately that can give you the total cost for a service. And then, you just have to keep track of all the services that are provided. And just briefly, it is worth talking about, a sort of hot topic in accounting and healthcare accounting is this idea of moving from cost-based accounting to activity-based accounting. This involves things like measuring, for instance, nursing labor directly and directly providing an estimate of cost on that rather than sort of jamming that into all of the other things that you can pay for directly. It's kind of talked about really commonly. It's really hard to do. And so I think that's all that basically needs to be said on it. The next topic is what should we charge for something, right? So you figure out how much something costs. The next you have to figure out is, okay, we know what it costs, but if we say we need to get paid exactly what it costs, then we have 0% margin and we are literally just covering our costs and likely don't have enough money to continue to stay open. So, basically, how do we take our costs and mark those up? The important thing to know here is from again, a sort of logistics standpoint is this is created through charge codes. Charge codes for a hospital are like the primary fundamental piece of how do we manage our billing for things. And basically, this exists as, so first, let's create a list of all of the services and types of billable things that we can provide, right? So imagine an Excel spreadsheet with like hundreds of thousands of rows of here are all of the, terminology codes for all of the services we can provide and all the equipment we can use. And then each one of those things gets a unique internal proprietary code, which is basically unique to every hospital or healthcare system's accounting system. And that would be their internal charge code. And then that allows you to associate a dollar amount to each granular atomic thing that you can bill for and keep track of it from one master place. That one master place of all of the list of the codes that you can bill for and the way to identify them uniquely and the charges is the charge master. The charge master as a document and an accounting tool is a primary piece of responsibility that hospital accounting is responsible for. It is also really important because oftentimes you will see the charge master either referenced to in I would say, like regulations or laws that are passed, or referenced in things like, cost analysis or, even in research. So again, we'll talk about this a little bit more later on, but so if you followed all of the regulations and executive actions in the past 10 years on price transparency in the American healthcare system, basically all of that has ultimately relied on charge masters. CMS creates rules or the White House, the administration creates executive action saying you need to release transparency on your costs. And very simply, hospitals say, no problem, here's our charge master, figure it out if you can. Yes, did I see your question? Yes, as a matter of fact. So the question was, is that like where the numbers on an EOB and explanation of benefits come from? And that answer is yes. So typically, if you get an EOB, that would be coming most often from your payer. And what they're going to show is, okay, so we got a bill, for this service. And typically it's going to be like a HCPCS or a CPT, and it's going to say, your provider sent us a bill for a 99,214, and the dollar amount on it was $197, and we paid back, $27. And so basically what you're seeing there in that EOB is the charge, typically at essentially the one line or couple of line subset of the charge master. And then you're seeing the payer's negotiated rate or payment response on it, right? So again, it takes a lot of understanding this to know what's happening, but you're basically seeing there the charge coming from the charge master and the payer side of, we see your charge and this is what we respond with, something that is 1/10 of the value of that. And so again, here, I have this sort of simple visual at the bottom of extending again. We were talking about the total cost, and then the total cost for something becomes a charge with, typically some markup for margin, some markup for negotiation. But, this sort of magic where we have, without actually having insight into a hospital's accounting, you have no idea how that markup is being done, right? Is it a flat 10%? Is it, again, this is a service that we, for some reason, can charge a lot for, and so it's going to be $1 billion, right? Like, even if we understand the process that goes into the charge, without having really deep, detailed internal information, you have no idea how the cost relates to the actual charge. And this is really important because, as I get to later on, oftentimes people rely on charges to try and do research and make very simplistic assumptions about the relationship between cost and charge without having any of this information. Okay, and so now kind of the final piece of this thrust, how are payments calculated? So we've gone through how are costs identified, how does the cost become a charge? And now so we have charges, how does the payment get calculated? So this is now moving from the provider onto payer dynamics. Okay, so we've talked about before, payers know that charges are marked up, right? This is just part of the known arms race. Almost universally, payers are going to pay less than the charges that are coming across from the providers. Payers and providers, they typically engage in negotiation to develop contracts on how payers will pay. These negotiations can change. Sometimes it might be a flat percent off, like, for whatever reason, hey, for this population, we're just going to take your charge and we're going to pay you 60% of the charge. And that's simply the payment on every patient that you get for this contract. Sometimes it might be very granular, in terms of we're going to go through, the charge master or a subset, and we're going to go negotiate, individual pricing on a range of services. There are all different ways to doing this. But basically, these negotiated rates between the payer and the provider then become the negotiated rates for some specified period of time in a contract. And then those become the payments that the provider is going to accept. And this is where I was getting at before. Contracts are usually payer specific. So it's sort of crazy, but, take UNC and Duke and WakeMed and, all of the various hospitals or healthcare systems just in our Research Triangle Park area. Typically, all of these will have their own managed care departments that are individually negotiating with individual payers over all of these different contracts. It is a huge amount of work and effort. And another piece to know is that market forces and other dynamics are relevant to this process, right? So large payers, by volume, typically have some more leverage when they're negotiating these rates, right? So this is where a lot of times you have seen consolidation of healthcare systems, right? So smaller and more rural hospitals can join in, and there are a lot of market forces, leading to this process. But one is, as you become a larger and larger healthcare system representing more patients, you can have more leverage in negotiating lower negotiated rates with payers. But then there are also just things like geographic and cost of living factors that go into this, right? So a national payer like United Healthcare, they are going to expect to have less room to negotiate in Manhattan than in a rural state somewhere, right? Like the cost of living, the wage index, the fixed cost structures of certain places are just higher. And all of those types of things go into the negotiations and the contracts for these. And so having talked about the how are payments calculated, right? Or what's the process there? Now we have to move on to talk about sort of more the actual payment mechanisms, because depending on the type of care, the actual payment execution is different. Um, and this is where we go back to the concept of professional healthcare versus facility-based healthcare. So professional being, physicians or other providers and the care that they provide, versus facility being things like hospitals and the care provided in hospitals. So basically, within the US, we have two major reimbursement mechanisms depending on your care. This is where, again, it is the reality of this becomes more complicated, especially as we've worked with more innovative and complex payment mechanisms that our data science lab seminar next month will get into more deeply. But this is sort of the bottom level floor of this topic. You have fee for service and prospective payment. So fee for service is the typical payment mechanism, reimbursement mechanism for professionals. And it is literally just you keep a list of all of the stuff that you have done, and then you send that list in and you expect to get paid for it, right? So you're a physician, you see a patient in your clinic, you consult with them, you get some labs drawn, you write some prescriptions or maybe give them some vaccinations. Each of those things that has a discrete billable code you write down. You have, a charge code for those, a charge amount for them. You put those onto a claim, you send them in, and you expect to get paid for all of those. Although, again, like we saw in the ERB example, it's going to be some, negotiated rate on those charges. Ever since about the late 70s or early 80s, though, facility reimbursement has taken a very different mechanism, which is prospective payment. And so this applies to hospital inpatient, and now more recently, it also applies to hospital outpatient. And rather than this list of fee for service, where you just keep a list of everything that happens and get paid for it, this is more you categorize a care into a certain high level category, and then you get paid really globally for all of the care that you provided or all the services you provided based on the category. And this is done by generating a totally new topic, the DRG. So this is a data-based really categorization tool, the diagnosis related group, that then facilitates prospective payment at a categorical level, right? So instead of paying for all of the care given based off of a list, now you're simply basically given a flat amount based off of a category of care, regardless of the individual details, that happen for that care. And so getting into just a little bit more detail on these, right? So fee for service explains, right? So like I was saying, simply generate a list of stuff, services, equipment, and get paid for that. So I'll explain the rationale for this, but historically, throughout parts of the 20th century, fee for service was the reimbursement mechanism for all care. That changed in late 70s to early 80s for facility, but it is still the case for professional. And so this basically happens at the physician level by taking these granular units of care, so typically HCPCS like CPTs, and converting them into standardized units, relative value units. This is important to know because, again, this is where, while both a rabbit hole to go down into, it's where so much of the cost and the subjectivity of this reimbursement happens. So there's a lot of fighting among professional groups and the government in terms of the relative value unit, right? The relative value unit is basically the dollar amount that you set for the individual unit of a provider's work. So take something, like a simple office visit and say that that is set at, call it CPT 99 to 10, and everyone agrees that is equivalent to one relative value unit of medical work. And then typically, based on a long list of things, cost of living, wage index, geography, a dollar amount is set for that relative value unit. And they'll say one relative value unit is equivalent to, I'm just making this number up, $37. Then what they do is they look at every other service that can be provided at a HCPCS level, and they calculate relative value units for all of those things. And this is essentially how fee-for-service reimbursement happens, right? So you have this long effort in negotiation between typically CMS and a physician representing group to really figure out what should the value of one unit of our work be, and then what should the relative amount of work associated with every single service that could be provided be. And the thing that's interesting on this, as you might imagine, is it gets subjective at some point. So 90, I have these examples down here, 99 to 12 is, at least the last time I checked, equivalent to 0.7 RVUs. It's not even worth one. That's basically like an established patient visit to an outpatient clinic versus a 99 to 14. That's a moderately complex patient visit. But you can see these are like very medicine types of patient facing, talking about problems and, offering up professional insight. Where things really start to get aggressively hairy and combative is in procedures. And so I happen to know a lot about vascular surgery. My wife is a vascular surgeon, and so this is an area I think about a lot. I give here an example from vascular surgery. So a procedure of a vein ablation is approximately 30 RVUs versus an abdominal aortic repair is 50 RVUs. So the first thing that you can see is proceduralists are wildly more valued in the RVU system than medicine, people that don't do procedures. But the thing that's interesting is you might just look at this and naively think like, well, vein ablation, that's some type of procedure that's probably complex and requires a lot of insight and maybe has a lot of medical malpractice risk. But this is where, I say the magic part. There's a lot of negotiation and trade effort that goes into this. So something like a vein ablation is actually, I would say, from a surgical standpoint, considered a relatively easy, low risk type of procedure. And this gigantic technical component gets negotiated into the relative value unit where, well, this requires oftentimes use of a laser or some other device that requires training and all these types of things. But in terms of like a risk or a technical competence standpoint, something like a AAA repair, which is potentially a big, complex, very risky, open, abdominal or open chest surgery, like is disproportionately potentially more risky than something like a vein ablation. And yet the vein ablation gets a huge number of RVUs. And so this is where you can see lots of things that start to happen, right? So one, you start to incentivize medical trainees, if they're interested in getting paid, in moving towards procedural areas, because RVUs prioritize that. Another piece you start to see is a lot of gamesmanship at times from professional societies in terms of carving out, things that are disproportionately valued relative to other things. And then you see sometimes unintended consequences of that. So one thing that's really interesting is scope expansion and creep in professional scope of work. So for instance, while you pretty much have to be a trained surgeon to do something like a AAA repair, there are at times people from, say, non-surgical backgrounds that sort of do some lightweight training to get certified to do vein ablations and then open up cosmetic vein clinics because it's a very high work to pay ratio. And there's a fairly straightforward, or a much easier path to doing that than to going through the full training to become a surgeon in cases. So same thing, you see something like in dentistry, at times there has been a real interest in some areas of dentistry to expand their scope of work to maybe say like some facial surgeries, or even some cosmetic surgery. And again, all of this is ultimately being driven by RVUs, and both the way the RVU is valued and the way relative RVUs are set to each other and priced out. So this is where I say lots of effort that goes into the negotiation in the granularity and the modification of these. Yes, question?
Provider. Are these negotiated at that level? It sounds like they're more broad.
This is typically at a full, it's sort of two parts. The RVU and the costing of the RVU, that's basically set at a national level. So it's usually CMS, and there's, at least as far as I know, one major physician group, the RUC, from, I think it comes from the AMA, the American Medical Association, that gets together to sort of manage, discuss, and negotiate. Like, okay, and I think it's annual. Like, all right, this year, what are our updates to the RVU system? And typically this is published in the RBRVS, the resource-based relative value scale, which, at least from my experience, is like a telephone book size compendium produced, I think, every year of here are all of the updates to every procedure code, and all of the different RVUs and the modifications and all of the technical pieces that these groups are talking about and negotiating at a national level for that time period.
Okay, on top of that, because the national group said it's 2 RVUs. We think you're doing it for cheaper. We'll pay you.
Yeah, I mean, and so a lot of this is really focused on the government level, right? So a lot of this focuses on like often the Medicare policy. Like, so within Medicare, Medicare identifies, the vein ablation as 30 RVUs, for example. And that would equate to whatever this dollar amount is. But then, the individual provider could take that dollar amount as, and mark it up as a charge and send that charge to a payer, and that's where the payer can negotiate on that as a private or a commercial payer. Yeah, let's see. Summarize the question. What's that? Oh, I'm just trying to remember now.
At what level RVUs are negotiated compared to?
Oh, right. So the question was on what basically the difference between the negotiation of uh, developing and negotiating RVUs versus negotiating and developing the charges. And so the process of, how does, say for the fee for service side, how does that move from the HCPCS to negotiating the RVU and the dollar amount associated with the RVU more at a national level, to then the individual provider level of how does that dollar amount then become a charge and get negotiated with individual providers or between individual providers and payers. Okay. So now switching from fee for service to prospective payment. So basically, the problem that the United States had over the course of the 20th century was that fee for service basically incentivizes doing more to get paid more. Even if you are not a malicious person who is intentionally trying to sort of drive up your bill as high as you can, what you see at a mass population level is if you have the ability to get paid individually for more stuff, you tend to see people generate and bill for more stuff. And so this is where sometime around the late 70s, early 80s, the United States basically decided, and this was particularly dangerous on the facility side where costs were very expensive, right? Like you have big services, long stays, expensive capital, just generally more expensive stuff than individual providers could bill for. And so having a hospital send you a list of all the stuff to get paid for was resulting in these like systematically astronomical bills that they needed to do something about. And so the solution was to implement prospective payment. So rather than retrospective payment, where we say, which is what fee for service is, which is you send us the bill for everything that you did, and now we pay you for all that stuff. They wanted to move to prospective payment, which is we don't really care what you did. We know you provided this type of care, and we're just going to pay you categorically on this type of care, right? So here's an example. So, provider sends a bill and they say, all right, patient was in the hospital for an appendectomy and they stayed for 2 days. Different provider says patient was in the hospital for an appendectomy and it was 15 days, right? So if you don't know, 2-day hospital stay is going to be typically much less expensive than a 15-day stay. That's like an extra 13 days of services and stuff happening, which is expensive in a hospital. Being paid under prospective payment, the answer might be no problem. Both of you get $2,000 because both of those roll into the DRG, the diagnosis related grouping for appendectomy, right? So it becomes irrelevant how much stuff you do or how expensive the care was. You get paid on the category of care. And this is where, there are entire compendiums. You could devote probably most of a life to just researching the evolution, the development, and the calculation of DRGs, right? And then the prospective payment aspect of this, which I will not go into here. But the goal here is basically you want to incentivize the provider to perform efficient care, right? So rather than saying, well, you have an incentive to performing as much stuff as possible because you're going to get paid for all of that, now they're saying, well, the financial risk is largely on you, right? So if you can provide the care faster and more efficiently, you should, because then your chance is that you're going to make margin off of this as a category. I guess the other piece to know is, so, Medicare was the first group to really implement prospective payment, but the way healthcare typically works in America, whatever Medicare does, typically all payers adopt. So Medicare adopted prospective payment and DRGs, again, approximately the early 80s, but every other payer pretty also quickly followed onto that. So I transition now into just some end content on different topics that I want to cover. So there's a lot of information. I know. I know we're at time, but I will take some time to try and respond to questions on any of these, various topics that are pretty dense, I know. But so one thing I wanted to talk about was sources of expenditure data, potential sources of dollars in healthcare that you can actually get to. So AHRQ, the Agency for Healthcare Research and Quality. This is a great source for two research-focused data sets, HCUP, Healthcare Cost and Utilization Project, and MEPS, the Medical Expenditure Panel Survey. These are two really primary sources of cost and expenditure and utilization data that are used all the time in health services research, in health economics research. These are places where you can actually typically get to not just charges, but actual costs. And I think payments, I can't remember exactly. But like these are expressly designed and collected to facilitate high quality research on expenditures in healthcare. There are technical aspects to them, but both of these have tons of research and support on how to use them. And then moving beyond that, CMS has some data sets that can be useful. So the CMS physician fee schedule is published. This is sort of related to what I was talking about in terms of RVU calculations in the RVRVS. This is a data set where you can basically see coming from the government, and focused on Medicare, which is again the largest payer and really the driver of much of the decision making and policy around a lot of payment. This is how the payments are being set up for all of the different services, right? And so if you're just trying to estimate like, what's at a national level, how much is, the Medicare population, costing for something, you can at least kind of start to estimate from the provider side using the physician fee schedule for certain services. There's also the retrospective Medicare provider utilization and payment data. I have not used this recently, but historically, this was a great data set because over, discrete periods of time, Medicare would actually publish at a provider level those providers' utilization for Medicare of specific services, and then both how much they were, essentially billing for certain services at a HCPCS and CPT level, but also how much they were costing, like how much they were getting paid for those services. Similarly, CMS publishes the inpatient hospital public use file. So that's similar to the provider utilization, but it's from the hospital side. And then same thing for the CMS outpatient hospital, right? So just different sides of the facility piece, the inpatient hospital and the outpatient hospital. There's also hospital price transparency data sets. So this is something worth talking about in more detail. So if you have not followed this for something like the past 10 years, every couple of years, the government has attempted to up the bar of this. So basically, somewhere around, I don't know, 2010 or 2015, the government started saying, we want more transparency in expenditures data. And so they keep trying to sort of regulate some amount of transparency in the healthcare sector. And this started out by saying, all right, hospitals, healthcare systems have to publish machine readable files of charges. And so that's where, hospitals would essentially publish their charge master somewhere to be in line with these regulations. Generally, every version of this that comes out, providers and over time, payers have been included in this, that payers need to disclose some of their costs or payment information. Basically, all providers and payers hate this, and they have lobbied against it. They have said that these are trade secrets or proprietary. They shouldn't be allowed to, they shouldn't be required to disclose them. And the thing that's interesting is, even though many of these are requirements, like there has been some research on this, and like there are lots of providers that just don't do anything. And for the ones that do something, they do it in the most obtuse way possible, right? So like they'll bury a link, 100 pages deep on a website. So technically it's available, but God help you trying to find it. And even the ones that maybe make it available, they make the data to be so accounting-y that unless, again, you really have a pretty good idea of what you're looking at, it's very difficult to tell, like, is this a charge? Is this a payment? Is it a cost? Lots of them break out these dollar amounts over every single contract they have. So rather than just saying, well, I want to know about the costs for this type of patient, for this type of service, they make you do it at a contract level, not even a payer level, but a payer contract level. The other thing they typically do is they aggregate it. So they'll say, well, this is the average of this, or maybe the median. So again, there's just a lot of gamesmanship in terms of how do we sort of attempt to do this in a way that we would argue legally is in the spirit of what we need to do without actually sort of giving a huge amount of transparency into what we do. Yeah, I think it might be interesting at some point to actually show some of these data sets in a seminar and sort of do a hands-on walkthrough, but that's for another day. And then finally, I just want to talk about, like things that you should really think about if you're interested in this, like things that you should not do. So one, don't use charges. Like they're really convenient. People still talk about them all the time, and they come up with these rationalizations. Like, I'm just interested in utilization, and so charges are good at that. But like, just don't use charges. Try to use something else. Even if you're interested in just utilization, just count units of something, right? The number of days, the number of HCPCS or something. Like that is vastly more interesting and helpful than saying these were the charges associated with something, because again, the charges are a made up number, and comparing charges between institutions or sites is basically meaningless. So another thing, we haven't talked about this, but don't use a charge to cost ratio unless you're using HCUP. This is another thing that you'll sometimes see people do. In this type of research, a lot of times you'll see people say, like, well, I know charges are different than costs. And so I've used a charge to cost ratio of 0.8, right? And so my assumption is charges are marked up by 20%. Except again, this is essentially made up unless you know a lot about the accounting level information. And so I believe it is HCUP. They have basically published a standardized charge to cost ratio that you can use because they know a huge amount about the accounting level markup between the charges and the costs in the data set, and they're making that known. But again, it would be meaningless to take, for instance, the HCUP cost to charge ratio and apply it to some other data set because it doesn't apply to that accounting system, right? This is I don't know how frequent it is anymore, but at some point in the past, parts of my grad school, you saw this often. People said, like, we use charges and then we use the CCR to estimate costs. Don't do it. Another piece that is oftentimes overlooked is taking dollar amounts from multiple years and just combining them together. Like, this is wrong. If you have dollar amounts from different years, you have to inflate and deflate to a common year to make them comparable to each other. So this is just a major methodologic piece. And there's a ton of resources you can find on this for inflating and deflating to a common year using the medical CPI. Another thing, and this is getting even more methodologic, is costs or dollar amounts are never normal in like they don't have a normal distribution when you're looking at it in analysis. And so, it's common then like, well, we'll just log it and we'll do our analysis with the log dollars. But then people will just treat those log dollars like they're normal dollars in their output, right? So be very careful and mindful when you're doing this analysis, in terms of how are you manipulating the dollars, and then ultimately what can you do with the analysis of that. I mean, the good thing is, if you're interested in this, like, there is a wealth of methodologic information out there on a lot of these topics to support you. Okay, and with that, I will stop and just pause for questions. And also highlight that you can always go out and view any of our recorded seminars, including the previous one, on the healthcare system and kind of fundamentals leading up to this in terms of healthcare system and translating into process and data. Okay. At the top. Why isn't healthcare accounting data more available at public institutions? I mean, there are probably a couple of different answers to this. I would say the most common is because it is, from the provider's perspective, it is their trade secret, right? So, um, if a hospital really made their cost information known, then I think their perspective is their market competitors know a lot about their business practices. And so they have a sense potentially at how to compete with them, or maybe how to, underprice them, or how to steal market share from them. Um, I think this is probably the most common, I would say, argument that I see on this topic is, just people feel like there is a lot of providers feel like there is a lot of danger to making any of these sort of costs known in a public way, and it can affect the ability of them to run their business or to compete with other institutions. I mean, another piece of it is, if two institutions had, their granular, say, payments disclosed, the thing that would happen immediately is every hospital would look at all of their competitors' payments and figure out, like, well, how much am I being paid for this and how much is my competitor being paid? Because if I'm making less, then I'm going to go back and I'm going to tell the payer, you need to pay me this because you're paying this other person this. I think there's a lot of this sense of, escalating an arms race into even higher levels. And I'm not, I guess I would also say, I don't know that I am advocating that this is right or wrong, but I think that these are the justifications that are used for this is why this information is a trade secret and why we are not really going to disclose it in a direct way. Yes, question.
Last. That's last slide was sort of like all the reasons why you should be really careful when using cost data sets. I only really used health data, never any cost associated data. So what kinds of research can you do by bringing in sort of cost information that is available?
Yeah, so it's a more general question in terms of, what kinds of questions or what kind of research can you do by bringing in, expenditures or these sort of dollar related topics and data into your clinical research. Um, you know, I think I think the sky is sort of the limit. Like I think every clinician potentially has a different perspective on this. I mean, the immediate things that you can come on with are, figuring out things like burden of illness and cost of disease, right? And so these are a lot of topics that I would say, um, national and international level health economists spend time dealing with, right? So like, what is the national cost or burden of disease for, hepatitis C? And you can think about that from sort of a raw healthcare expenditures standpoint, right? Like this is the direct amount of care that is provided to support just the effects of this disease. But then it can get expanded out too, right? So like what's the direct plus the indirect costs, right? So what is all the downstream sequela of these diseases, and then what's all of the care provided to that? And then, I would say another big part of it is actually starting to look at relative effectiveness of things. This is something that I allude to in the policy part, but the United States is one of maybe the only, certainly one of the few industrialized countries that Congress has basically forbidden from looking at costs relative to value in terms of treatments or procedures. And so, like, it's explicitly excluded from the approval process at the FDA. So, if you look at somewhere like England or Germany or other places, they typically, when drugs or therapeutics or other things are up for approval, they'll look at both the effectiveness and the cost of something. And so, if you have drug A that treats a disease, and now a new pharmaceutical company creates a new drug and it's 10% better, but twice as expensive, a lot of those countries have mechanisms and tendencies to say, it's not really worth it. Like 10% benefit is not worth twice the cost. But in America, we are explicitly forbidden from looking at that type of analysis or factoring that into our approval and regulatory process. And so I think there's a lot of interest and ability to look at that post hoc in America. Um, so interestingly, though, the federal government essentially will not fund that type of research. So for instance, if you're familiar with PCORI, the Patient-Centered Outcomes Research Institute, they're forbidden essentially from funding cost effectiveness analysis. This is why we talk about comparative effective analysis, where you have to look at the effectiveness of treatment A versus B independent of the costs. Um, these are they're very politically charged topics in America. And so, on an individual researcher level, you potentially have the chance to try and look at some of these things in interesting areas. And I think that there's a lot of value associated with this too. Even if you look at, um, so interestingly, I would say one of the major drivers, it's speculated, and I think there's a lot of evidence for this in America, is increasing technology. So even if you look at something like the surgical space, there are things like the Da Vinci surgical robot, um, which gets used in areas like gynecologic oncology, urology, maybe general surgery. But it's a very, very expensive piece of equipment, and it has very expensive maintenance contracts that you pay to the developer, the provider of that equipment. And You know, there's some research that doing procedures with that device potentially have some benefits, but it's incremental benefits. But these technologies then sort of move on to become marketing tools too, interestingly. This is where the consumerism piece sort of intersects with so much of this, right? So as one hospital gets it, it becomes a marketing tool. So every other competing hospital sort of has to rush to get these same things. And all of this then leads to escalation of prices and, you know, competition on a lot of different things. And so, you know, this is where, I mean, I just think that there's almost an unlimited sort of availability of topics down into every medical specialty where you can look at not just the effectiveness, but also the effectiveness relative to how much something costs, sort of in your clinical area, both at the very large scale, right? So, like, how much do things cost at a national scale, all the way down to, you know, like, how much, you know, does it actually cost to provide this care to our patients, you know, relative to the incremental benefit that they get, you know, compared to something different. So, I mean, that's a long-winded answer to try and justify it, but I think that's what I would say. All right, not seeing any other questions. I'll just thank everyone for your time. We'll look forward to seeing you in August for our next seminar on more advanced payment mechanisms. And thank you for attending.